It is now midday at our end here on Wednesday. I realise it's going to be Tuesday evening for our beautiful guest here today. So, tēnā koutou katoa. Welcome to the second International Learnings webinar series for 2025. And this is about gathering insights and aspirations and inspiration from leaders across the globe. And I see we've got both local and international guests joining us. So to all of you, a huge welcome. Before we begin, I'll open up with a karakia or a blessing in Te Reo Māori, which is the indigenous language of Aotearoa, New Zealand, and then I'll introduce myself before a little bit of details around the format of today's session and then an introduction of our fabulous speakers. All right, so he karakia timatanga koutou. Me mahitahi mātou, ka kōrero, ka whakarongo, kia atawhai, kia manaki, mō ngā whānau, me no hapori katoa. Kia rātou te tino rangatiratanga I o rātou haora. Kia pai te taha tinana, te taha wairua, te taha whānau, me te taha hingari hoki, haumi e hui e, tae ki e. So in English, that blessing said that we will work together and communicate with kindness and respect for the benefit of our community. So our people will have self-determination or autonomy over their health and well-being for a well body, spiritual well-being, family well-being, and mental well-being, and unified together and strong. So greetings, ko Coral Fitzgerald toko ingoa. My name's Coral Fitzgerald. I work for Collaborative Aotearoa and I am based in Otautahi, Christchurch in the South Island of New Zealand. I'm one of 4 passionate staff members as part of Collaborative Aotearoa, and I'm delighted to be facilitating this particular session today, which is the second of our international webinar series, following our inaugural event back in February with Chris Reid from the UK. For those new to Collaborative Aotearoa, the pursuit of equitable health and wellbeing for whānau and communities across Aotearoa is really at the heart of everything that we do. And through collaboration with our amazing membership organisations and which are across both the primary and community care arena, we're deeply committed to expanding our reach to bring transformative change to healthcare delivery across Aotearoa. I'd like to acknowledge at this point as well and thank Amarjit Maxwell from Think Ho Ora, which is one of our PHO members who introduced me to Jodeme. We've got this connection kicked off. So a few housekeeping notes before I introduce the speakers. So the session is recorded and it's going to be available on our website over the next 24 hours. The chat function is off, however, you're very welcome and encouraged to use the Q&A function, so please feel free to enter those as we go along today. You can also interact using the React button. And just to note, I've got my fabulous colleague Nee in the background supporting us, who will monitor the Q&A, and we have some dedicated time at the end of the session to explore those. So without further ado, it's time to meet our amazing 2 presenters that you see. What I'll do is provide a brief introduction, and of course they're very welcome to dive a little bit deeper when they start their presentations. So our first speaker is going to be Jodeme Goldar. Jodeme is the founder and managing director of 4C Impact Limited and a recognised leader in the systems level transformation in health and social care. Jodeme's passion is noted as convening opportunities and building capabilities, inspiring people in health and social systems to work together so that they can realise the potential of the collective to achieve population health and well-being. So welcome, Jodeme. Our second speaker is Dr. Alika Lafontaine, and Alika is an award-winning physician. He's a social innovator and the first Indigenous physician listed by the Medical Post as one of Canada's 50 most powerful doctors. From 2013 through to 2018, Alika was co-led the Indigenous Health Alliance, one of the most ambitious Indigenous health transformation projects in Canadian history. So Alika continues to write and speak on the politics of healthcare, implementing and scaling equity, redesigning health systems, and effective advocacy. Wow, I'm so excited about this next hour. You two are powerhouses in your own right, and we're so excited to hear from you about your gems of wisdom. So thank you for joining us on our Tuesday. For you, it will be your Tuesday evening over in Canada. Great to have you here, and a reminder to people watching live to use that Q&A function. So I'll now hand over to you, Jodeme.
Coral, thank you so much. It is such an honor to be here, and thank you to Collaborative Editora for the invitation and for me to be able to hold space with you along with Alika. It is a true honor. A warm welcome to everybody. It is wonderful to see you, although I cannot see you. I know when we hold virtual space together, we show up in ways that we can feel each other's energy. It's a kinetic energy around a shared passion for improving health and well-being around the world in the communities that we live in, and it is a true honor. A little more about myself. I am a daughter. I am a mom to three and two dog. I'm a mom to dogs as well. I'm a sister, an aunt, and I have a life partner. And those elements really ground me in the relational aspects that mean most to me at the end of the day and why I've always been so driven around this work. When I was 12 years old, I started volunteering with older adults and their families. I had this propensity to just spend time where people had a lot of lived experience, had experienced life over many years, and I'd always been drawn to listening and understanding and providing a space to listen and understand. And I fast forward to when I started working, moving from volunteering to working. And when I received my degree in social work and I was meeting with older adults and their families, I started to understand that as people and their families were trying to navigate our health and social care system, despite the great, amazing work individuals do or organizations do, very often we are not meeting the needs of people and their families. People and their families go to heroic efforts to make systems work that aren't designed to focus on necessarily what's most important to people and their families and what each of us define as well-being. In many health and care systems around the world, Western health and care systems, we're focused on responding to sickness and illness. And the question that sits in front of us right now is how might we together bring about health and well-being for all? And my career since that time has been dedicated to that question and working in the spaces in between, the spaces in between clinicians, the spaces in between organizations. May they be in our municipalities, in public health and hospitals and home care, doctors and nurses' offices. May they be in shelters or organizations providing food security or housing security. The space in between, asking always, how might we work together so that we can bring about health and well-being? How might we partner with people and their families and communities to do the same? So I have spent the last 30 years exploring the how might we, also learning how can we, and being mentored and gifted many gifts along the way that have helped inform the presentation I want to share with you tonight. Well, tonight here in Ontario, Canada. I know many of us are in different time zones. At the end of the day, I like this saying that if we convene, coach, the capability, then together we're able to achieve something that is bigger than any one of us, a collective impact so that we can have collective action, so that together we can be the counterforce that brings about health and well-being and understands in a sacred way what that means for people and their families and what that means for those of us that work in health and social care, how it might require a shift in how we've been taught or how we might be delivering care, or perhaps turn our head to centuries of wisdom that could help inform traditional or Western approaches to health and care, and always asking ourselves, how might we build our possible future and build it together? When I started working in the space in between, I was looking for where is there energy around this work around the world? Is it named within an integrated care mindset? is it a lever, integrated care, to bring about population health? And when exploring around the world, I discovered that, and many of us know, in old developed countries around the world, there are health system policies that have prioritized integrated care as a lever for population health. And yet, when we get deep into community, there's often a gap between what we say we want and the conditions in which we're able to deliver on the promise of health and well-being. And in developing countries, it's also starting to become a priority. And we know that no matter our community, there's so many of us who care very deeply around shifting to health and well-being, and how we might need to work in ways that change the way we show up so that we can, in fact, deliver on the promise. And when we think about integrated care and population health, although our systems are converging in terms of policies to advance it, the how we do it is different all over the world. And there is a lot of evidence now that to be high performing, to achieve health and well-being, and to be able to, in fact, address some of the quality indicators that the Institute for Healthcare Improvement says is important in the diagram on the left, or perhaps to your right, is there are a number of enabling conditions that will help set us up to be successful. And during this process of discovery for me, I discovered the International Foundation for Integrated Care. That's how I've come to you today. It was through relationships that I have built over time, and that have been built with me over time, which is a community and a movement for change around the world that is intended to inspire, influence, and facilitate the adoption of ways that we can work together to enable community health and well-being, which is an inclusive process where every single person is part of change, feels a sense of belonging, and the systems, formal and informal, are focused on what is most important to people in their families. When I discovered the International Foundation for Integrated Care, I was actually facilitating a strategy in my local community and in my country to help connect up different parts of our health system to work together in ways that could understand what is most important to people in their families, and could shift the way we were working, actually to come together at the point of people in their families, at the point of care, at the point of community. And I started to share some of the work we were doing in Canada and learn from other countries around what they were doing. And in that process, I was lucky enough to fast forward to today, where I serve as the vice chair for the International Foundation for Integrated Care, the global or international movement around integrated care, and then co-founded the North American Center for Integrated Care. And the reason why I want to mention this to you is that this is a hub of the larger organization. But when we think about movements for change and the global movement to enable health and well-being, and to shift our health and social care systems to work together in ways that actually bring about health and well-being, we know that based on the evidence around what helps us be successful with large-scale change, is although we're looking at change at a large scale, we need to be able to touch and feel it. We need to be able to connect in our local environments. And we set up this center so we could connect up all the efforts in Canada, people in communities that are bringing about health and well-being, that are challenging the status quo, that are challenging traditional or Western approaches to respond to health and become more inclusive, to learn from one another, to learn together, unlearn together, grow together, and have impact together. Now, when we developed the North American Center for Integrated Care, what we didn't expect, but what has been an incredible experience, is that we started to become recognized as the accelerator for change, because we were taking a collective impact approach. We asked ourselves, how might we be the convener for large-scale change? How might we connect up, each of us doing this work, to learn from each other and to be part of a broader movement? And the piece that I appreciate so much is the relationship that has been developing and has a long history, but just my own personal experience with all of our colleagues in New Zealand. And I appreciate the hearts that are coming through. When we hosted the North American Conference on Integrated Care in Canada just this last fall, we were joined by many of your colleagues, and a commitment to ask ourselves, how might we work together in more relational ways? How might we learn together? And today is a build from that incredible opportunity. And the second is on June 10th, you may or may not be aware, but Amarjeet from Think Aurora and Kat Patterson will also be joining us through the North American Centre for Integrated Care and the Hub in Canada to talk about how might Indigenous ways of knowing and being be a foundation for integrated care and population health. Because as our systems are looking to recalibrate around health and well-being, the knowledge systems that are in developed countries are not always the knowledge systems that will bring about health and well-being. And there are a number of partnerships that have started to emerge, and I know Alika will be speaking in more depth around this, that can help inform a much broader approach to bringing about health and well-being in the country, in all of our countries, and how we might be able to leverage the learnings. And what I find so incredible is, from a theoretical perspective, there are 9 pillars from the evidence that are shown to bring about health and well-being by leveraging integrated care. But regardless of the pillars, there are 2 critical elements for success: understanding our intention and creating the environment that enables us to thrive. And at the heart of integrated care, and if we are really serious about considering integration, how might we work together across our organizations and are breaking down silos so we can work together as one, so that people actually feel that they are part of something bigger than themselves, and that health and social care organizations are responding to what's important to health and well-being. It also gives us the opportunity to understand the ways in which our social, political, and historical systems have created inequities in the first place, and go to the root causes, and I hope create a counterforce or a course correction. So when we ask ourselves, so in order to do this, how might we pattern our possible future? I appreciate the notion that the future belongs to those who hear it coming, and what are some of the elements that we hear coming. And for those of us online today, for this next portion, think about yourself, the teams you work with, perhaps the organizations, your partners, our families, how we, for ourselves, define health and well-being. And I appreciate Bill Sharp's model, because sometimes in the first horizon, we may be making incremental changes or thinking we're going about change in a way that's helpful, but in fact, it's reinforcing the status quo. When we ask ourselves, what are the new patterns? What are the ways in which we want to be ambitious? And ambitious may be rooted in relational ways of working that can help us reach a new possible future. So I'm going to spend a few minutes on some of the ways in which that patterning affects our mindset and our behavior, and some of the lessons learned. Some of the lessons I have learned, and that I have learned in partnership with many others around the world, around if we could just do a few things, what might they be? And the most important piece, and Alika and I had time to touch on this earlier today, is that at the heart of the most meaningful change in the world comes from the extent to which we are present, and the extent to which our mindset and our behaviors are genuinely and deeply situated. What I find so interesting is that when you look at So if we want to bring about really meaningful change, the question is, how do we shift to a shared purpose? One purpose that we have in common, no matter our organizations, if we're in primary care or community care or hospital care, or if we are a community member living in a community or receiving care or wanting to share what's most important to us, or a person who is supporting somebody, a caregiver, supporting somebody receiving care. Movements for change happen when we come together in shared purpose. And when we start to shift our mindset to understanding that although what we do in our organizations or in our practice is important, what is more important is when we work together, what kind of impact can we have? And how do we tell a story around the difference we can make when we work in partnership with each other across organizations or sectors in health and social care, in equal partnership with community? And when community self-determine for themselves what is most important, and we become guests as part of their own vision, which means moving to an ecocentric view. Where am I situated in the context of a broader community? Where is my organization situated in the context of a broader community? How might we be in service of what is most important to people and their families? Now, I'm not sure in the partnerships in Collaborative Artora where this is at in your journey, but in Canada, for instance, our health and social care systems have been designed to be separate. And so we have to go to heroic efforts to work together. And very often, our health and social care organizations and people that work with them are attuned to what is important to our organization, while also responding to what's important to the people that that organization serves. It's incumbent upon us to say, how might we together shift our mindset and our focus to the broader community? And although this is very relevant in Canada and many developed countries around the world, it's also an opportunity to walk a step or two in each other's footsteps and say, how might I understand where you are coming from? How might we leverage each other's strengths so that together we can bring about health and well-being, which is actually backed by the literature in abundance theory. Abundance theory will say, although within an organization or within a clinical or non-clinical practice or in the community, we might feel that we have scarce resources. We know we're dealing with workforce issues. We know we're dealing with funding issues and perhaps not all the right policies that enable the change we want to see. But from an abundance perspective, we actually have a ton of capability. But have we really unleashed our capability in how we work together, how we understand what is most important to people and their families? And it's a shift to a new power response, which is how we see change. We share power, we relinquish power, we understand the how power has shaped really poor outcomes in many of our countries, and a very deep need to listen and to become connectors with one another. A colleague of mine has termed the concept of relational reciprocity. How will we work together in ways that are deeply, deeply relational and allow us to not impose solutions, but enable community to be self-determined, to tell us who work in health and social care, how might we be in service? How might we become interdependent in enabling and supporting? And how might we center our relational focus? How might we be deeply, deeply relational in how we connect, how we are attuned to what is important? And then how do we take that to understand the skills? Given the level of complexity that is required to bring about health and well-being, no individual and no individual organization can match the level of complexity, but together we can. And within that is a need to think about, how are we showing up? Am I an expert? Or am I a convener of the collective so that we can together have the answers emerge? Now, experts are really important in certain areas. I know if you had a surgical intervention, you wouldn't want somebody who isn't an expert. However, when it comes to system change, the expertise actually lies within all of us. What is missing sometimes is bringing us together to unleash our expertise and to create a movement for change. Movements for change are highly relational. It's not a mandate or a strategy that we are asking people to buy into. Instead, we are co-creating what is important and how to shift our health and social care systems to be more inclusive. These are teachings that have been gifted uh, to me personally from many, many people. But it's a shift from a Western worldview to one of kinship and one that is very common in indigenous teachings. And I know Alika will speak very specifically around what does this mean? But we can see that when we look at the opportunity within each of us to consider how might we be the counterforce, how might we support enabling health and well-being in our communities. What we have learned is that there is a very, very relational aspect. And that relational aspect, no matter what we do, no matter our role, no matter where we are, if we remember that connection is the correction, then we always have a guiding post around how might we enable a possible future that brings about health and well-being. I think I'm going to stop there, Coral, if that makes sense. I'm looking at the timing. I'm happy to share more after if that works for participants and our timing, but I want to stop now and transition to Alika and then come back to answer any questions or have any conversation that may be helpful.
Beautiful. Thank you, Jodeme. That was so rich. Thank you. At the moment, we don't have any specific queries on that, but I'm sure as people are mulling and percolating on that, something will pop through. So we'll lean into Alika and then come back together. Thank you.
Right. Thanks, Jodeme. Jodeme and I actually met during a leadership program that she helps run over at McMaster University, which is one of the universities in central Canada. And it was a great opportunity for me, even as kind of a late stage leader, to get to connect and kind of wrap my head around new ways of thinking about things. And I think that that's probably one of the most useful parts, I think, of these webinars. You know, you're caught up in your day-to-day things, you know your context, you know what you're trying to accomplish, but anytime that you can look at the same thing in a different way, I think it has some value. And hopefully, as you kind of look at both Jodeme and my presentation, you can take away some of that value. I'm going to share a little bit about myself. Bon après midi, Alika Lafontaine, Malolale. This is my mom and dad when they first got married. My mom was born on the one of the villages in Vava'u in Tonga, and grew up in Nuku'alofa. I made her way over to California, like a lot of Pacific Islanders, and my dad ended up meeting her, and I'm not sure how he convinced her. This is probably a different presentation, but she came up to Saskatchewan, which is a province that can fit California inside it, and has about 1 million people. He grew up in a small town of about 100 people in a town called Lestock. And they built a life there. And the weather in Saskatchewan is very different than the Pacific Islands. It's minus 40 degrees Celsius and has winds that go up to 60 kilometers. I think the coldest day I've ever had in Saskatchewan was minus 68 degrees Celsius. It was the coldest place on the planet. You walk outside and your whole face just, freezes. But I now live in northern Alberta, which is a place that's high enough in Canada that I get to see the Northern Lights every night. And who I am really helps to shape kind of how I approach the presentation. So my mom and dad, had a bunch of kids. This is me in California when we were visiting my grandparents in Millbrae. Like a lot of Pacific Islanders, we got involved in singing and other things. We actually started a boy band. This was before medicine. We ended up performing across major theaters in Canada, and then my mom told me I had to, get a real job, and so went into med school. Ended up graduating in 2006, and since then I've been a part of system change and trying to improve systems, not just for Indigenous peoples, but also for folks across the country. I've, like many people, have been a part of task forces and reports and sat on boards and all of these other things. And one of the things that I take away from all of this is some of the patterns that Jodeme has shared, and some of them that I'll communicate as I talk about the Indigenous Health Alliance. In 2022, I became president of the Canadian Medical Association. So I was Canada's top doc for a year, leading our 94,000 plus physicians across the country. During the year that I was president, I had the opportunity to share and form a lot of health system change using a lot of the techniques that Jodeme has mentioned, and things that I've learned prior to becoming president. We had a historical federal investment in healthcare in the budget of the year I was president. It was 196 billion. We ended up talking about pan-Canadian licensure. I think in mainstream it had always kind of been around the edges, and then it was kind of brought into central discourse. We ended up setting up a lot of things, which I think has benefited us well with the changes that have happened in the world, and people from our southern neighbor now considering whether or not they want to continue practicing there and maybe moving up here to Canada. There was a refocus on primary care. I think for many years there was a swing away from generalists and people who provided primary care in communities towards more specialty medicine and having people leave the places that they live to go to other places to receive care. And so there's been a pendulum that's swung back in Canada towards that again. And then focuses on Indigenous health. One specific thing that I'm really proud of with my presidency was leading a 3-year shift within the CMA, where we actually gave an apology on behalf of the medical profession to Indigenous people for harms that were suffered, both historically and today. The Indigenous Health Alliance was a project that I became a part of prior to becoming president. And it was really a place where I consolidated a lot of the things that I had suspected about how change works in healthcare systems, but didn't actually have a chance to watch them happen in real life. The IHA was actually founded by 3 First Nations in Saskatchewan. In Canada, there's 3 different Indigenous groups. There's First Nations, there's Métis, and there's Inuit. Each of the Indigenous groups have their own specific history and their own kind of relationality as far as treaty with Canada and the Crown. Once again, I'm Red River Métis, but the First Nations were working with people that I knew, my father, and other elders that I had learned from over the years. And so we were all brought in as part of a team where we were asked the question of, why are we so sick? And so that's really where the 3 communities were coming together. They were having these crises surrounding physical violence, addiction. People were dying at a very high rate. The fentanyl crisis had not yet made its way into the mainstream, but it definitely was there in the community at, the peak of the crises that were happening there. We were having, 3 or 4 funerals every week. So you'd actually have a wake, and then you'd move one person out, and then another person would come into the community center to have the wake for them. And the community was incredibly frustrated with the response of the healthcare system towards the very clear crises that were going on. And they were being pointed in a whole lot of different directions. No one wanted to take a responsibility. And at the same time, the communities really felt like they were being blamed for what was going on, instead of there being kind of a shared collaborative type of approach to the problems. And so we approached in 2013 the question of why are we so sick, meaning why are the people in these 3 communities so sick, around the frames of healthcare rights, quality improvement, patient safety, and patient-centered care. And as we started to grow out the project, we found that a lot of the things that I took for granted as a trainee within the Western healthcare system was more or less non-existent. within the First Nations that were receiving care. One concrete example, if you go into a hospital in a mainstream healthcare system that's regulated by some type of centralized body in whatever country you might be from, there's certain rules that people have to follow. Generally people have the opportunity to have autonomy. They make choices about their own health. There's an expectation of confidentiality. You don't just get one choice. You're given a variety of different choices about what you have for care. If you're unhappy with one provider, you can go talk to at least one other. You're not told this is just kind of how it is. And at the time in 2013, and this has changed over the years for sure, but at the time, there were things like negotiated absence of care. So people would actually be told you get a doctor for 3 days a month and that's it. And so if it's not those 3 days, then you actually will not receive any care. And then the responsibility would be placed on the individual and the community to try and facilitate how do they access care. If you had a concern about patient safety, something that clearly should not have been done, there actually was no mechanism to report that. You'd often get mixed collection and storage of medical records. Jodeme said in her presentation, Canada's really separated out our health and social systems. Within First Nations at the time, everything just kind of went on the same pile. So you could be asking for antipsychotic meds in order to keep your mental health condition under control. And in the same pile will be requests for education funding. So you could go off and get a degree and get a better paying job, or housing requests or other things. And so there really was no separation within the way that people collected and stored information at the time, which were the expectations that anybody would have within a healthcare system for how things worked. And so as we started to see these differences, and we took kind of a multi-perspective point of view to the problems, we start to realize that the question of why are we so sick was actually the wrong one. The right question was, why is everyone so healthy? Like, why do we have this pocket of sickness and crisis, and less than 100 kilometers away in the towns that bordered the First Nations, they had hospitals, they had access to care, they had emergency services, people were not struggling with the same sort of mental health, overdose issues, physical violence, etc. And I think because of that frame, the alliance actually grew pretty rapidly after that. We eventually included more than 150 First Nations. That's more than a third of all First Nations in Canada. We had 24 national medical organizations, more than 24 that signed on to kind of the movement, and really looking at why is everyone else so healthy. It at the time became the largest Indigenous health transformation project in Canadian history. And we secured 68 million in funding that went forward to operationalizing a lot of the things that we found during the project. So I'm going to talk about the story through a couple of different diagrams, and Jodeme actually presented this one in a different way. This is the Three Horizons diagram. It's one that I really love because it talks about how systems disappear and how they come into being. And so everything follows patterns. And I think that that's one thing that I've always appreciated, that I've been taught through my grandparents and my parents. Whether it's looking at the seasons or it's looking at the times of your life, there's always some sort of pattern out there. And so I've been preconditioned since I was young to kind of look for patterns that are out there. And the Three Horizon framework actually describes this really, really well. So there's three horizons to change. In the first horizon, the way that things are disappears. And so the things that we accept as kind of normal, status quo, eventually disappear and are never to be seen again. And so one common example is like technology. My kids have never seen a rotary phone. Everybody knows what a rotary phone was if you're of a certain age. My kids do not know what CDs are, or CD players. So that technology disappears, but health systems also go through the same sort of thing. In the third horizon, the future emerges. And so who would have thought that today on your phone, you'd actually have all of the world's knowledge at your fingertips, right? That you could download and stream movies at the same speed that you could do with a laptop. I remember when Apple TVs first came out, it would take 2 or 3 hours to download things. If it was a very big movie, it wouldn't be uncommon to take 12 hours, you know. And so the future as it emerges, it does give signs. And just like Jodeme was saying, you can hear the future, but you don't actually know what it is until it kind of stabilizes and entrenches itself. The second horizon is the transition point between Horizon 1 and Horizon 2. And so this is the point at which the past disappears and the future is still emerging, but you still don't know what that looks like. Right? Does all the past disappear? Does only part of the past disappear? When it comes to the future, which of the things that you're hearing is actually going to be part of the song that will be played over the next few decades? And so when we were working through with the Alliance, we were taking all these different ideas and kind of thinking through, how do systems and the stories that underlie them actually shift over time? And so there was this model that I created with my dad called the social dynamics of change, and it's pretty straightforward. At the baseline you have your status quo, and that's just the resting state for where things are. It's where people are kind of comfortable with how things are. It doesn't mean that the status quo works well. It's just that's how people expect things to be. Now, whenever you have a status quo that doesn't work for people, in particular that it works bad enough that it creates bad things, right? So, for example, the status quo of not having patient safety or quality improvement programs within Indigenous health actually led to a lot of crises because the same problems would happen over and over again, and it wasn't until the crises happened that anyone would notice that they were happening, right? And so, when your status quo leads to crisis, you get this uptick in people's willingness to kind of let go of the way that systems are. Let go of the beliefs and the ways of doing things that they initially considered was the right way to go about doing it. Now, that crisis eventually feeds into people considering whether or not they actually want to change. And so you can see that the crisis peaks and then it goes down this gentle slope towards this stage called denial. Now, denial is the place where people intuitively push back to change. You're not really sure why you don't like it, you just know it's not normal, right? And so the reason why it's a gentle slope is because it's not really organized. It's not like a organized resistance to what's trying to happen. It's just that people sit and say, well, that's not how we do things. And that was a common thing that we heard quite a bit within the Alliance, especially when we sat down with government. This is not the way that we go about doing things. This is not the way that things are organized. One of the common refrains was, we are not a health delivery system. So you can't expect us to run things like a health delivery system. And so people push back at this stage because they don't feel that things are right, but they don't always articulate, why they feel like things are wrong. It's just kind of this intuitive pushback. Now you can see as you go down the slope, there's actually a very sharp slope that goes and bottoms out as far as people's willingness to change. And people really try and hold on to the status quo at that point. And this downward dip is a stage that is labeled as resistance. And what resistance is, it's when people actually have to shift resources, right? When people have to change who they report to, when they lose money in their budget, when the person sitting beside them might lose their job or get reassigned because what they used to do is not really what they should be doing anymore. People will organize themselves to make sure that the change doesn't actually happen. And so where denial is kind of this intuitive pushback, resistance is this organized, forceful entrenchment of the status quo. And whatever system you're trying to change or wherever you're at with discussing things, I would expect that some of this probably rings true in your lived experience. Like you sit in meetings and you're trying to explain, why things need to change, and people just can't see it. And it's because their way of seeing the problem is so much different than yours, right? And I think that's where that collaborative, in Canada, we call it indigenization, like bringing together, indigenous ways of knowing with Western systems. That's when people start to shift kind of what they believe and how they see problems. Resistance is often hidden. People won't come straight out and say, I'm not going to do this because I'm going to lose my job, or I'm not going to do this because I'm no longer a sustainable business model. One of the most striking examples of this through the career that I've had with trying to make change was working with the national or the provincial and territorial regulators towards having a consistent way of regulating across the country. I still believe, and I think there's significant evidence to support this, that the reason why we don't have a consistent approach to regulation across the country is because it's not a good business model, right? If you have a regulator in Saskatchewan, where I grew up, and a regulator in Alberta, that's a per head count collection of fees. And so now when you bring those two together, who gets the money? How much money do they get? And how do they continue with the work that they need to do with a model that no longer pays in the way that it used to, right? This also feeds into changes in the way that primary care works now. For physicians, why do physicians kind of see themselves as the quarterback and kind of the director of the teams? One of the big reasons is monetary, but then other things are regulatory and risk related. And so as you work through your different problems, kind of splitting those things into like that intuitive kind of belief-based pushback and that resistance, that thing where someone's reaching into their pocket and taking out the resources that used to be there, will kind of help to frame what's moving forward. So if you get past resistance, you then get into exploration, which is where people start to make little changes that are reversible. But you're starting down that path of actually creating a new status quo. Once you get to commitment, you've actually made the change. So you passed legislation, you've done other things. We moved over to a provincial electronic medical record system. I was facility chief at the time when it happened, and I still remember the night before they turned it on. We were shredding papers, and the person who was leading the project was sitting there with me as I was listening to these papers getting shredded. And I asked them, well, what are we going to do if this doesn't work? Which is a reasonable question with software, right? And the response was, I don't know, but you can't use these anymore. And we just continued shredding in silence, and then she left. I was kind of sitting there thinking to myself, I don't know what we're going to do if this doesn't work. So at that point, we had committed. It was no longer exploration. That was a commitment stage. After a commitment happens, then you get to a new status quo. And that new status quo eventually becomes maladaptive, just because the world changes and the things that people need change as well. And so I kind of group these three together. Status quo, denial, and resistance kind of fit together. Crisis is kind of off by itself, and then kind of the blue part is the parts where you're kind of moving on to change. Now, exploration, commitment, and the new status quo is where people often look for change, right? That's where our MOUs sit, and that's where our calls to action sit. And when we try and sit down with folks and say, can you commit yourself to this change? In reality, crisis is what drives all the changes that are happening. It's actually the only energy in the entire system that pushes through the stages of denial, resistance, and status quo. You start to get a little bit of a pull when you move over to exploration, commitment, and a new status quo, but that is never powerful enough to overcome denial, resistance, and status quo. Now, when you're in a situation where you feel like over and over again, nothing's changing, I would suspect that you're probably caught in the same cycle that we were trapped in when we were trying to make changes and we couldn't overcome the intuitive pushback that people had or the organized resistance against resources shifting. And so as a result, you have a status quo leading to crisis and going through this cycle over and over and over again, where nothing really changes and you eventually just reset back to your status quo. Now, the really dangerous part of that, and I think one of the reasons why crises are really getting a lot worse, especially in Indigenous communities across the world, is because crisis is not a static thing. It's kind of like a downward spiral. If folks have not suppressed their memories about COVID, one of the things that I noticed in the very early waves when I was facility chief was we were all called into these meetings and we were asked questions about how to react to the pandemic. And we gave those answers, and then the wave would subside, and then the new wave would come, and we'd get sat down to ask the same questions and give the same answers. And, in the first couple of waves, that was something that we expected. There was turnover, it was very confusing. There was a lot of things that were going on. We were very forgiving to the decision makers who we were trying to influence to change the approach. By the fourth and fifth wave and onward, A lot of people in our department had just checked out. People were just saying, why sit down for another 4 hour meeting if anything that we say actually doesn't make any difference? And so as you go round and round that circle, there's a weathering that happens where the things that used to be carryable, like the heaviness of crisis, even if it's the same weight, actually feels so much more heavy until you eventually snap. And I think that that's one of the things that we recognize within the alliance, and one of the differences that uh, we decided to do as we move forward working with community is really using a trauma-informed approach, recognizing that people were not disinterested in changing healthcare. They were just let down so many times that they didn't actually believe that it could happen anymore. So just to return to what we talked about at the very beginning, the first horizon, the present disappearing, the third horizon, the future emerging, and then the second horizon kind of being the transition period. We're all trapped in the second horizon right now. And one of the things that I emphasized to the folks that I worked with when I was leading the CMA and all the government work I continue to do is that this feeling of instability and this feeling that the rules that we used to follow no longer seem to be followed, that's actually how it feels to be here. Like that is actually how it is, right? And so the challenge that we have in this stage of the second horizon is to realize that the best part of it is that anything can change. The worst part of it is anything can change. And so we're forced into this direction of whatever happens. And being able to hear the future and shape the future is going to create and entrench that third horizon, that future that we can't see yet, but is coming into being. And those changes are going to reverberate for generations to come. And so at this point, happy to turn to questions. Thank you.
Oh, amazing. Thank you so much, Alika. That was incredible. I see we've had a comment, someone had to pop away, but they've saying very inspiring presentations, which is beautiful. So our lovely Armajit, Maxwell's got a question. Her question is, how can Indigenous ways of knowing guide us in reimagining systems to create a more just and sustainable future for all? A future that centres Indigenous knowledge, encourages system thinking, invites collaboration, radical collaboration, and focuses on health equity.
Sounds like a 2-minute question.
Yeah. So it's a good meaty one. Thanks, Armajit.
Yeah, I do have a suggestion for that, and like one of the challenging parts is like mine and Jodeme's context can help to inform yours, but it's different, right? Like everyone has different realities for how the environments are that you're trying to make the change, and then also kind of the root of your beliefs. So being Tongan, I think I do have like some understanding of Maori culture and traditions, but it's still not the same, right? And that's one of the beautiful things I think about indigenous ways of knowing is like we recognize we're not like homogeneous. Everyone has their own, legends and culture and tradition and generations of learning that we've inherited, right? In Canada, with First Nations in particular, I think there's probably three perspectives that are kind of pushing against each other. There's kind of the status quo look at how sovereignty works within healthcare, which is really I get to make choices about myself, but it's within the restrictions of the system that I'm in, right? And then you have the traditional way of looking at sovereignty, which is that it's this inherent gift from the creator that's based on generations of learning and culture and traditions. It's more about making good choices in a good way than it is about making choices restrained by context or environment, right? And then you have the legal definition of what sovereignty is, which is the ability for you to act on your own, right? So it has nothing to do with collaboration. It's just you get to act on your own. And so if you were to draw like a Venn diagram and kind of layer over stuff, if you had, the legal definition and the traditional definition, that's where inherent jurisdiction comes from, right? Like your right as a nation to make decisions about how your healthcare is built. If you get an overlap between kind of legal and the status quo way that sovereignty is looked at, that's where your standards of care and other things come out of. If you get an overlap of the status quo way that health systems look at sovereignty and tradition, you get a sort of culturally informed type of way of providing care. But the real center, and I think the solution is, where do all of those overlap? Like, what does that actually look like, right? And I think the answer to that is something that I don't have for participants, but I think that's kind of how you get to it, And I think that that's one of the things that I've always appreciated about Jodeme and kind of the work that she does is, it's kind of a process of how do you work through these multiple different perspectives to get this layering, so you then can take the best or the essential parts of everything, and create a new shared truth. And I think that's the toughest part that I've realized about healthcare. At the very beginning, I thought strongly, if only we protested loud enough or we created enough legal risk, things would change. But the reality is, you have to build shared systems. Like, there's no way around it, And so, yeah, that path it's a hard one to walk, but at the end of it, I know that that's where the solution is.
Maybe build on that, Alika and Amarjeet. Thank you for the question, and Alika for the recognition that this is highly relational. It is actually the process is the change. And I think part of what you're saying, Alika, that really resonates for me is we can't just be stuck in patterning our possible future. We have to set out our intention. Where is it we're trying to get to? So when we are patterning a process, a way of connecting, a way of deeply understanding, so that so what can emerge is the truth and the path that we need to take, then what happens in the end is achieving our potential, possibly. And Amarjeet's a great example. We just got off a session planning for that virtual session, and Amarjeet is partnering and actually saying, I want to learn and I want to understand, and I'm committed to a long-term process. And so her Indigenous partner and our, mine the same, will say, then I trust you to share my teachings. I trust to walk alongside you. I trust that together we'll bring about health and well-being, and we'll grow and we'll learn and we'll have humility. And I think sometimes what comes up all the time is a paralysis or a fear of, I don't know the answers and I don't want to get it wrong, so maybe I won't even go forward. And sometimes that resistance or the denial is fear. And when we walk a step or two and we have the relational humility to understand and say, let's keep moving forward, this is, I think, when my words, the magic occurs, and we start to change culture. We start to change the way we show up. And hopefully that means we start to change health and well-being.
Gorgeous. Thank you. We've had a couple of more questions come in, which we'll get to, but I think this last discussion has led into one from someone who featured on the presentation, Jodeme, for his kororia, Johns. So she says, tēnā koroa ka mihi atu mō tō mahi. Also, greetings to you both, and thank you for your work. She is curious, as wahine Māori, a Māori woman, that she knows and feels everything is connected and struggles at times to communicate that in my tacit way of being to non-Indigenous partners when supporting awareness. So she's asking, do you have any insights beyond your amazing presentation around effective communication across different lived experiences?
Yeah, I can maybe talk to the provider frame, just because I had my upbringing, and then that was trained out of me, and then I had to find my way back, after it was purposely pushed out. I do think that providers, especially within the Western context, we all inherited this idea that, the body and spirit are disconnected. The best place as a provider is to actually be distant and cold and disconnected from what's going on, because you're an observer. And I think as part of that, there's often a denial of the power that people actually have. You sit across from a Western provider and you're like, well, you need to help me get access to this, or you need to, and they sit there and go, well, that's not my job, right? I'm just here kind of passively observing. And we know in in all practical senses, providers are as much of a part of the team as you, right? Like their decisions, their bias, my bias as an anesthesiologist, it influences the way that you have care. Whether or not I allow, an annoyance from earlier in the day to seep into the way that I interact with you, or how I decide to react to, you know, a patient who's having like a very bad day. That's one of the things that I've always appreciated about anesthesia, and one of the reasons I was drawn to it is, you're more or less seeing people on the worst day of their lives, right? And so I think one of the things that I learned from, my mom and dad and my grandparents, through like our culture and tradition, is that, you embrace your power, you embrace your role, right? You recognize the parts you can play to help to respond to the pain that people are feeling, right? And sometimes that's not a very comfortable thing. It's not easy to hear somebody yell at you for, 10, 15 minutes, and at the end of it, be able to get out that trauma. That way they can refocus on what they really need, and to recognize that they're not actually mad at you. They're just mad at a system that's failed them over and over again, right? And so I would recommend for providers in particular, like helping them to embrace the power that they actually have, and to recognize that they actually have a role. Like they're not there as a passive observer. And one thing about healthcare that I think has come as a result of the burnout discussions that we've been having, particularly among physicians, is that one of the reasons why burnout exists is because you haven't brought your whole self to work, right? Like you haven't found that place where you actually feel like you're a part of something before. And I think we did that informally back in the day. Chief of staffs in Canada would be people who dedicate their lives to running, health systems without being reimbursed. It wasn't actually a formal title or a formal job. It was just something that you were assigned as kind of the leader. And that disappeared, I think, over 30 years. And I think we're starting to see a bit of that back. And, the more we can inject indigenous ways of knowing into that, and that relationality that Jodeme has talked about, that bringing your full person, I honestly think that that's the way back. Nobody wants a hostility field encounter. No one wants to feel like they're just a cog in a wheel. If you can become a part of what's going on, but then recognize your relationality and like your power, but then also the rights of the person that you're treating and their power, and help to increase that, I think you have a recipe for kind of figuring stuff out.
Thank you, Kara. Good to see you. I can't see you, but warm hello. The other piece, and a build on what Alika is saying, is that I have found the power of convening to be incredibly powerful. So when I shifted to saying to myself, I have the responsibility around the teachings, I don't. I have the responsibility to convene so people can learn together, and perhaps create ways in which we can learn, reflect, apply. So what does this mean for us? What does this mean for the way we're showing up? What does this mean for the way our care is provided? What does this mean for how it's being experienced, and people coming who have different lived experience? And when I started to convene those groups in Canada, I initially got a lot of pushback because it sits outside of the way people generally come together to learn. We learn within organizations, we learn within professions, we learn, and this was saying, no, we are going to choose something that is going to help us thrive as a community. We're going to choose to learn, and not just learn cognitively, but have an embodied experience so that we understand what this actually means, and what this means for how I am thinking about how I show up, how it means that we are in connection with each other. And, having met you in person, I know you're a convener for positive change and good in this world. And the roles of the future includes us being conveners, brokers, facilitators of the collective, so that the answers emerge, but we have to create the conditions that enable that. And it has a very powerful impact on change.
Mhm.
I hope that's
You know, maybe,
helpful.
yeah, maybe I'll add too to that you have been kind of thinking about the power of protocol, right? And
Yeah.
I think from a Western point of view, like protocol is kind of like organizational line of authority, right? But it's not really in like an indigenous sense, right? Because our protocols are split into kind of more political, kind of practical decision making, and then the spiritual sense of our being, right? And I think one of the hardest things for uh, practitioners who are not familiar or understand kind of how that whole thing works is they don't get why an elder can come into a room and tell me this is what's happening and then walk out and I'm just like okay, and then suddenly I'm just doing it, right? And I think that understanding of um, how to make those, like I said at the beginning, that sovereignty that's traditional, where you're making good choices that are good for you, but also in a good way that's informed by like generations of tradition.
Yeah.
Right. That's part of I think the blind spot for a lot of folks. They think, well, I ran these numbers and the numbers tell me to do this, so we should just do that. Right. And you're like, well, you can't actually do it that way. Like this is the protocol for how we interact with each other. And getting explicit about that. And I know when Jodeme works through these problems, one of the things that I experienced during the health fellowship modules was like getting a explicit articulation of like what these actual rules are, right? But maybe sitting back and kind of thinking through that, like it's claiming your power, but it's also realizing that you don't actually have power in some situations, right? You actually shouldn't be making choices in some situations, and I think that's something that Indigenous peoples are raised with, and I think we don't always realize that that's how we make decisions, right? Because we're surrounded by it; it's just normal, right?
Amazing. I think we've got time for either one or two more. There's a couple that have come through actually from the team. So they kind of blend into one. So I'm gonna state both and then we can do a quick fire response. So I know you mentioned our health sector seems to be in a state of constant change, and after 20 years it feels like we've come full circle in how the system has reformed. How do we continue to support those feeling frustrated or reluctant to change while staying true to who we are? And how do we build a sense of shared existence through it all? So that also leads into Marama's comment about what are some strategies you both use to help those who resist change, and they're often those who benefit from the status quo, to be open to it.
You want to go first, Jodie?
Sure. How many times have I had the great honor to facilitate change and ask myself that question? And what I've learned over time, and I'm also part of the Institute for Healthcare Improvement with all the global practitioners around large-scale change. So I'll bring in some of the gifts and lessons from that. Is first, you go where the energy is. Very often we spend a lot of time on those that resist the change. And I know this may seem counterintuitive because a lot of people who resist the change hold formal power or have power in other ways. And when we continue to go where the energy is for the change, then the energy for the change continues to grow. And back to what Alika said, when the energy is around good intention and we go about it in a good way, over time, what happens, like a movement for change, and movements can change for change can be for good or not for good. I'm talking about when it's for good, the energy gets so big that the resistors start to get smaller. And I had this amazing full circle moment I'll share quickly with you. I was doing a leadership program. I was a student in the leadership program, and it was about health system leadership. And all the examples in the entire program was based on hospital leadership. And I had just started working in integrated care and population health. And I said, there's a big disconnect for me. And so the head of the program was really upset with me. And he was like, so if you're going to criticize me, you design it. So I designed a day. Okay, how might we bring about health and well-being? Okay, well, this is 15 years ago. Last week, he showed up in the largest conference for integrated care and population health in the world. And I play a role facilitating that movement. 1,700 people from 72 countries. and he showed up 15 years after the largest resistor. And so I didn't concentrate on him. And he had a big name, a big role, and a big formal institution behind him. I concentrated on where the energy is. And eventually there's a shift. Now, that isn't always the case, but I would say continue with our head down, do the work, do the good work with a good intention, create and build energy, and energy will beget energy. And somehow the rest shifts.
Yeah,
Gorgeous.
I think that's a great answer, Jodeme. And you know, I think just to layer on what you just talked about, like I think in healthcare there's like changes that are kind of iterative around the edges,
Mhm.
you know, and sometimes big changes are actually just a rebranding of the old thing, right? Patient-centered care at the very beginning, there were kind of two disparate paths that were being presented. One was actual real patient-centered care, and then the other one was a repositioning around hospital systems, right? And I think depending on the health system that you were in, you got one or the other, but we called it patient-centered care, right? And so I would say that with the change, sometimes it's not change, sometimes it's just
That's true.
rebranding. So just differentiate between kind of those two, just to add to the answer that Jodene gave. And then for the second part, like sometimes when I say energy around crisis, people misinterpret that it's like in the depth of the crisis occurring. But what it is the energy around actually solving the problem.
Yeah.
Right? Like when you move into the stages of denial, you lose your focus on the problem. You get more to what do I believe is going to work, even though you haven't actually made it work because the crisis has happened, right? Or when you get into resistance, you're asking questions around, well, how am I going to get paid? How are my team going to stay resourced? How do we still have a seat at the table that's influential? But that's not actually focused on the problem, right? And so I think what Jodene was talking about, where the energy is, and I think this is more true than it's ever been in the past since we're in Horizon 2 now. People want solutions, right? And they don't just want talk around solutions. They want people to do things and actually see that what they were asking for them to fix actually changes. And I'm doing some writing around kind of how crises continue to cycle and then spiral down. And I think that when you encounter folks who are really questioning like whether or not anything can change, what they're really questioning is like the shared social contract, like that social fabric that we have.
Yeah.
Right? Where it's like I've elected somebody and they're going to represent me. Right? People start to question that when problems don't get solved. Right? Or the social contract of I show up at the hospital and I'm sick. These people are supposed to help me. They start to question that. Right? And I think that that is something that I'm very acutely aware of in the change work that I do nowadays. You know, but there's an enormous energy there. It means that people actually want to hear people focused on crisis. You know, not to get political, but we recently had like our federal election, and the way it turned out was very different than what we thought. And I think when people will sit back and kind of pick away at what actually happened, I think one person was talking about solution like problems and solution fit, and the other person was just talking about problems. And I think that's just kind of how the ebb and flow of system change happens. And so just to underline what Jodene was talking about, if you can stay focused on problems, make it really clear how it's going to impact the things that you're trying to change, and just recognize that in solving problems for one group, you may be creating problems for another. You know, so you're kind of negotiating your way towards how do you get that problem solution fit, and everyone kind of gets enough, so you can move forward with the change instead of everyone getting always everything that they want. And then make sure you have those red lines, right? Know the things that you won't give up, the things that you absolutely have to have. You know, I think that there has never been a greater time for people like you to go out and make change in the world right now.
And make it with others together.
Yep, 100%. Yeah,
Make it together. Yeah.
none of it happens by yourself.
Yeah.
Yeah, that whole thing around journeying together for good. Absolutely. Goodness, that hour and a quarter has gone so fast, and goodness, the amount of the gold dust and the gems that have come through have been incredible. So just in the last couple of minutes, just to note there was another question which I might lean in and ask you post session to come back to us on. It's around the role of digital technology. I think it's an interesting one to lean into. And then if there are any others that pop through later, I'll flick those through. But goodness, I've been scribbling a number of the key themes that have coming through from both of you, and I think a couple of the key takeaways have been keeping in front of mind that even with the best intention, we often don't meet the needs of the families and the people that we serve. And so by challenging the status quo and being more inclusive, and I love that term that you used, Jodeme, about learn together and unlearn together. I think that's so powerful in terms of making a shift. And I love the abundance theory, that the fact that there is so much, there's so much not to have a deficit way of approach. And I think, in terms of the three horizons that you both touched into, I think that's so, I can very much aligned to what's happening in Aotearoa health system right now. You can see some of those modellings coming into play. And I think what we've heard today is going to be really help to buoy people through this change, right? So I really thank you for that immensely. I also believe this is the type of webinar I'm looking forward to watching the recording and listening again to absorb some more. So again, thank you so much for your incredible insights. And thanks to everyone that has joined us online, and for those who wish to watch it post-event. Just before I close, just a reminder that you're able to see this recording on our website, which is www.colab.org.nz, and just search for the webinar link at the top of the page. And once more, ngā mihi nui, many thanks to both you, Jodeme and Alika, for this. It's been an incredible time. Thank you. And I'd like to now close us with karakia. He karakia whakamūtanga koutou. Kia wānanga mātou, kia whakairia te tapu, kia wātia ai te ara, kia tūriki whakataha ai, kia tūriki whakataha ai, haumie hui e, tai ki e. Ka kite koutou.